Okay, hi everyone, welcome. So we're going to start with motor systems. You've already had some OSME potentially prep on neuro. This one is specifically focused on the motor systems. So we're going to talk a little bit about upper and lower motor neurons, about the muscle stretch reflex, the descending pathways, the cortical control of motor activity, that is to say, like control of motor activity within the brain. We'll talk a bit about the basal ganglia and the cerebellum. It says here that eye movement and pupillary reflexes are um, here. They're mostly covered in another lecture, which I think Laura will be doing. But there's also some slides at the end if you want to have a look. It's when you download the slides, which you'll have access to at the end of the lecture. And some topics, it should be mentioned, are not going to be covered in detail. So locomotion, interneurons, and so on. We'll try to keep it to an hour as I'm conscious of your time. This is really quite a big topic, I think, within the neuro curriculum, and it's something that quite often comes up on exams and people find quite tricky. I think the key is to take it in chunks and don't be overwhelmed. And I think my goal for this kind of hour-long lecture is to hopefully kind of demystify the main aspects and then also allow you to kind of go off and do more of your own studying for things that you find confusing or that you want more detail on for the exams. We're not going to go so much into kind of experiments and things like that for your essays, but hopefully this will be kind of good content revision for those MCQ questions and also getting just a baseline foundation in neuroanatomy, which a lot of people find quite difficult as a topic. So let's start with those upper and lower motor neurons. Um, so there's the way the nervous system is set up, and I'm sure you'll kind of all understand this. There's basically two types of neurons. There's upper motor neurons, which originate in the cerebral cortex and travel down to the brainstem. So I'm not sure if you can see my pointer, but oh, sorry, that's the change of slide. But the everything from the brain basically down to the spinal cord. So everything in green, the green line on this slide here, that's upper, and makes sense because it's kind of on the top end. So that's how easy to remember. That's really involved in involuntary motor responses, and it's not so much involved in reflexes. That the reflexes are done with the reflex arc, which we'll talk about in a little bit later in the presentation. The main neurotransmitter is glutamate. Lower motor neurons, on the other hand, begin basically in the spinal cord. So that's everything in blue here on this diagram. Everything from the anterior horn of the spinal cord and go on to innervate those muscles. So they connect directly to muscles, and the neurotransmitter there is acetylcholine. Basically, if you want to make a movement, well, the kind of synapses will start in the brain, go down the upper motor neuron. There'll be another synapse, go from the anterior motor horn of the spinal cord, and then it will go towards the muscle. So it's really important when thinking about the motor neurons to think about them split into these two halves, upper and lower, because clinically they will show up in very different pathology, and they act quite differently and they have different neurotransmitters. So this is a kind of crucial distinction in the motor system. So clinically, what's the difference? Well, in fact, you'll see quite profound differences in what you see in a patient that has, say, a lesion or a problem. We talk about lesions with neurons as opposed to just like a problem, but that literally just means like there's a dysfunction in a specific point. So when the dysfunction is in a specific point in the upper motor neuron, well, you're not going to have atrophy or fasciculations, but you will have things like increased tone, spasticity, and rigidity, which I'll talk about in a bit more detail. You're going to have pyramidal weakness, which means your extensors are going to be weaker than the flexors. And you're going to have certain signs, such as the Babinski sign. Again, we'll talk a bit more about that. That's going to be positive. Your reflexes are increased as well. So everything is kind of up. And I'm sure you remember that upper motor neuron has kind of increased reflexes, upper tone up on the reflexes as well. So a classic example would be a stroke. So that's an upper motor neuron lesion or something in the brainstem. Okay, or ALS or MS. So lower motor neuron, in contrast, you will have profound muscle atrophy. So what that means is that the muscles will kind of weaken and get smaller and smaller. So you'll see really, if someone's has atrophy in their hand, you're not going to see much muscle in their hand. They may have fasciculations, which are kind of fine wave-like tremors in the hands. We'll talk a bit more about why that occurs. And you have decreased tone, you have decreased power. So weakness is really in the affected nerve. So in that distribution of the affected lower motor neuron nerve. And with things like Babinski's, you'll have a negative Babinski sign, you'll have decreased reflexes. So upper, everything goes up, lower, everything kind of goes down, and that's a good way of remembering it. And that, classic pathology, so Guillain-Barré, spinal muscular atrophy, ALS, diabetic neuropathy, things like that. So now focusing a little bit more on the muscle stretch reflex. So remember, this is just within the lower motor neurons. This is nothing to do with the upper motor neurons. So this is a quite common topic that comes up on essays and MCQ. So it's something to kind of think about in detail clinically. So this is a monosynaptic reflex arc, so it can just be one synapse, and it doesn't even go up to the brain, so it kind of goes into the spinal cord and back out again. One way that I always remember that the kind of direction that nerves go into the spinal cord is I remember when I'm sensing something that, if I get a funny sensation, well, the hairs will stand up on the back of my neck. And that's how I remember that sensation goes on the dorsal side, on the back of the neck. Okay. Whereas any efferent neurons would go from the ventral or the anterior side. Ventral just means like stomach side in Latin. So that's the anterior side. So when you're sensing something, that goes from the dorsal horn. When you're efferent neurons will go from the ventral horn. So here, if we have, let's say, a source of heat or something that you stick your finger on, obviously you get your sensory afferents that go all the way up to your dorsal spinal column. You'll then get an efferent axon that goes from the ventral side and go towards that muscle. Okay, so that's one loop, and that's closed loop. It doesn't even hit the upper motor neuron system. Okay. And the integration center is that lamina number 9 of the spinal cord. And there's a difference in the kind of alpha motor neurons and different motor neurons in the muscle stretch reflex, which we'll talk about a bit later. So again, here is a different example. So this is the classic, when you kind of hit a tendon hammer on someone's knee. So what actually happens is that you hit the tendon hammer, and then that pulls a little bit on the ligament there, which actually gives a pull of the muscle. So then you'll have your muscle spindle will stretch out. That will create a neuron synapse, okay? That goes towards here with the dorsal horn of the spinal cord. Then we have some interneurons, integrating center. Okay, and you're going to have two different efferent paths. You're going to have one which is going to go to the quadriceps, which is going to create some pulling of the muscle. Okay, and you're going to have relaxation of the opposite muscle. So that's the hamstring in this case. Okay, so you're going to have some inhibition. You're going to have some use of one muscle while inhibition of the other. Okay, and most reflex arcs kind of operate in this way, and there's lots of different reflex arcs which clinicians use in the motor neuron to test basically, how well nerves are working. Okay, but the patellar tendon is kind of the classic one. So it's important to kind of remember things about the muscle spindle. So this is a kind of important part of the muscle that's involved with figuring out how stretched out the muscle is. Okay, so you have gamma motor neurons, you have type 1A afferents, type 2A afferents. Okay, and this is all within your extrafusal, and this is all within your intrafusal fibers, but you also have extrafusal fibers. Okay. So this is a kind of another example, just for your learning. So again, painful stimulus through the dorsal. You can have ascending pathways, so that's how you're going to feel your pain. But then the reflex arc is going to not use the brain at all, and you're going to have extensors might be inhibited while the other one contracts. Okay, and those are alpha motor neurons that are using that. It's doing that those efferents towards the muscles are alpha motor neurons. So a bit more about muscle spindles. So that they're situated in the fleshy part of the muscle in parallel with the extrafusal fibers. And they basically are just a signaling of stretch. So if you pull on a muscle spindle, then the neurons start to fire, okay? There's also things called Golgi tendon orners, which are situated at the ends of the muscle, so on the kind of terminal ends. And that's in series with the extrafusal fibers. And the signal tension is produced by muscle contraction, so you get inhibition. So Golgi's are kind of more of a measure of relaxation. And that's a bit more complicated, but less useful for the kind of a stretch arc. And there's also a role of proprioception of both of these spindles and Golgi tendon organs. So why do you have a gamma motor neuron? Well, So there's two neurons, as we talked about. There's the alpha motor neuron, the sensory neuron in the spindle, the alpha motor neuron, which gets the muscle to move, and then the gamma motor neuron. So why this gamma motor neuron? Why the extra neuron? The reason is because as the muscle stretches out more and more, you need a different neuron to figure out how stretched out the muscle is, basically to get feedback information so that the body understands how much firing is needed. Um, so the gamma motor neuron is almost like a redundant information to give a sense of how much stretch is going on. Because if you only had one single piece of information, say, oh, there is stretch or there is no stretch, you wouldn't have any information about how stretched the muscle is. And so you wouldn't have reflex arcs that occur at different stretch points, if that makes sense, because it would just be it's stretched or it's not stretched. Whereas if it's partially stretched, you need a gamma motor neuron to sense that. That's basically the point of the gamma motor neuron. And so that this is just another chart. So you have these alpha neurons and you have some gamma neurons, which are measuring stretch at the same time. Because as the muscle stretches, you're going to need redundant neurons to provide that information. So it's not just a binary state of stretch or no stretch, which would come from the sensory neurons. So what are the spinal levels of the major reflexes? You have biceps reflex, that the spinal levels are at C5 and C6, meaning that the spine at this level on the left here, that would be the C5 and C6 part of the spinal cord. And the nerve supply, so what are the motor neurons? Well, they're ultimately supplied by the branches of the musculocutaneous nerve. Brachioradialis, so biceps is kind of where the biceps is. Brachioradialis is more towards where the wrist is. That's also C5 and C6. It's a radial nerve. Triceps reflex is obviously the back of the elbow. That's where the triceps is, C6 and C8. Patellar reflex is L2 and L4. It's quite important to remember that's the femoral nerve. Achilles reflex, S1 and S2. So we'll talk a bit more about the Achilles in terms of clinical pathology, and plantar reflex is L5 and S1. And these are both the two bottom ones are both sciatic and tibial. So let's talk a bit about descending motor pathways. So there's it's pretty complicated. There's lots of descending spinal tracts, and there's some that are much more important than others, and then some that are way less kind of understood in terms of experimental evidence. So when you're learning, I think at least what I did is I learned about all of them equally, and I thought they were all equally important. But things like the vertebrospinal, reticulospinal, tectospinal, and vestibulospinal have very, very little clinical relevance. The main motor pathways are the cortical spinal tracts, and I think those are the most important ones to get a very strong sense of how they actually work. The other ones are important for your exams, but maybe a portion a little bit less time to knowing the exact ins and outs of the tectospinal tract, just in the sense that, first of all, the experimental evidence is not as clear, and what they do is actually less well defined and varies quite a lot. So of course it comes from that you have lots of sensory cortex, prefrontal cortex. These are all the cortical areas involved with movement. Okay, and then it goes down to either the cortical spinal tract, the rubrospinal tract, reticulospinal tract, tectospinal tract, vestibulospinal tract, and these are all distributed throughout the spinal cord. We'll see a diagram in a second. So on the left side, those lateral ones, meaning lateral within the spinal cord, are involved really with voluntary movement, and there's the medial ones. That is to say, they're in kind of those highways occur within the middle of the spinal cord, are more involved in brainstem control of posture and locomotion. Okay, typically clinically, if someone has brainstem pathology to they have many other problems, and so you're not so worried about their movement, because if they have clear brainstem pathology, they're going to have lots of other issues as well within the ventromedial parts of their spinal tracts. And a really important part to remember in this whole pathway is so obviously motor information, you decide to make a movement, that all starts in the motor cortex, okay? But all those will be spread out amongst the homunculus, which I'm sure you remember the diagram of the homunculus. So different parts of the kind of distal cortex here on the top of the diagram are going to correspond to different parts of the body. But all of the motor tracts run through something called the internal capsule, which is kind of in the middle of the diagram here, the internal capsule. And because all of the tracks are very closely situated next to each other, if you have pathology in this area of the internal capsule of the brain, you're likely to have very, very diffuse motor pathology across many different modalities. So you might have your leg and arm and face, for instance, or a whole side of your body will be affected. Whereas if you have just, say, ischemia or hemorrhage in the very distal cortical part, you're only going to have pathology, say, in your hand. So the important aspect to remember is the internal capsule has basically all the fibers in a very close bunch. And so if you get typically hemorrhage or ischemia to this area, it really has diffuse contralateral because it crosses over motor and or sensory deficits. And from a clinical perspective, the internal capsular problems are often from hemorrhages or ischemia to the thalamostriate or lenticulostriate arteries, and it have very high levels of disability. So strokes to the internal capsule are really bad. Importantly, there's also between the upper and lower motor neuron distinction, there's also the pyramidal and extrapyramidal distinction. So pyramidal tracts are known as such because they pass through the pyramids of the medulla, and they're really responsible for voluntary muscle control. This is a very kind of old school distinction that was made kind of in early experiments, and it doesn't actually track so well into, it's not a great distinction, and it's not a great term to be using, but you'll see it a lot in kind of textbooks, and you'll see it sometimes on the wards that someone will say, oh, this is really definitely an extrapyramidal problem. I think the easiest way to remember them is that pyramidal goes through the cortical spinal tracts, that's voluntary muscle movement, and extrapyramidal stuff usually just means they're referencing stuff that's problems that are happening within the basal ganglia. So those cortical spinal tracts, those can, as we talked about, converge to the internal capsule and then the pyramids of the medulla. About 75% of those will then decussate. That is to say, they'll cross over to the lateral side, while 25% will stay on the same side. And then they'll decussate a bit lower down at thoracic or cervical levels. And then you also have the corticobulbar tracts, which are responsible for voluntary control of the head, face, and neck. Bulbar always means face, basically in neurology. So corticobulbar means from cortex to face, and then further on to the cranial nerve nuclei. And that's mostly bilaterally innervated. Whereas the extrapyramidal tracts don't pass through the pyramids in the medulla, and those are more involved with involuntary control, like tone and balance and coordination of movements. And these originate in the brainstem, and they're definitely, the pathology involved is things like Parkinson's, Huntington's, choreas, dystonias. These are what we call the, problems of the basal ganglia, and those are extrapyramidal. But the distinction is anatomical, but it's not a great distinction. But just terms to be aware of. So here's just a diagram. So at the top of the medullary pyramids, those are your corticospinal tracts. About 90% are crossing over. It depends what textbook you read. 75 to 90% crossover. Some will stay on the same side. Okay. Just remember, pyramidal is your voluntary movement one, the main corticospinal tracts. Okay, so more on the cortical spinal tracts. These are really important to understand. Okay, so cortico meaning cortex, so the brain, spinal meaning the spine, so from brain to spine. Okay, so these are the primary motor voluntary movements tracks. Okay, so they run, as we talked about, from the cortex through the internal capsule, through the medulla, they decussate, they go to the lateral side, a small amount will stay anterior. Okay, and then they will connect with their respective lower motor neuron. Okay. And they also pass through the crus cerebri of the midbrain, the pons, into the medulla. And we talked about the kind of 75%, 25% split, okay? And there's a bit of a distinction in terms of the ones that are decussating early are more for kind of fine hand movements, whereas the ones that are anterior tend to control axial motor neurons, that is to say, like central motor neurons, but that distinction is sometimes helpful for remembering things, but not super relevant often. So just remember that about a quarter will stay anterior and not cross over until later down. Corticobulbar tract, as I mentioned, bulbar usually meaning face. Okay, so projections from the cerebral cortex to the cranial nerve motor nuclei, so in the brainstem. So the cranial nerves are the lower motor neurons, and the corticobulbar tracts are the upper motor neurons. These are usually redundant. That is to say that you'll have innervation of one side will come from both sides of the brain. So you have bilateral innervation of the head and neck muscles, except for cranial nerve 7, which is supplied only by the contralateral upper motor neurons for the lower half of the face. So the upper half of the face is bilateral, but the lower half of the face, you only get one side innervated. And cranial nerve 12, which is supplied only by the contralateral upper motor neurons for tongue. So 7 is the facial nerve, 12 is a hypoglossal nerve, and you should come up with some mnemonic to remember your cranial nerves. There's many out there. So why is it important to understand this distinction between bilateral and unilateral cranial nerves? So as we said, most of the cranial nerves are bilaterally innervated, but not all of them. And this is really clinically important in terms of stroke pathology. So here's a good example. So how do we distinguish between Bell's palsy, which is a facial nerve lesion below the spinal cord, as you can see on this diagram, there's the lesion there, versus a stroke, which is obviously above the spinal cord, is going to be in the cortex, okay? Well, we know in a Bell's palsy, it's after it's exited the brainstem, so there's no bilateral input after this point. So as you can see on this diagram, you have bilateral input, but it's the lesion is affecting both sides. Okay, so you're not going to get you're not going to be able to move a whole part of your face. So if someone has a Bell's palsy, they cannot raise their eyebrows or wrinkle their forehead on the affected sides. So that's a really good way of checking if someone's got a Bell's palsy. You say, can you raise your eyebrows? And they say, no. Okay, well, you know they don't have a stroke. Whereas with a stroke, it's an upper motor neuron lesion, which means they'll have that redundant other side, okay, that redundant other side, which is not affected at the lower part of their face. The lower part of the face has a redundant tract. The upper part of the face does not have a redundant tract. So they will have a spared forehead, okay? Whereas the lower side will be affected. So people with strokes classically just have a facial droop, but they will still be able to raise their eyebrows. And so you get someone in your stroke clinic or comes in A&E department, you think they're having a stroke, they can't raise their eyebrows. That raises the significance of the fact that they might be having a stroke. If they can't raise the entire part of their face is not working, that's more likely to be a Bell's palsy. You just give them some steroids, they'll be fine. These are very different pathologies, and it's just a nice clinical example of the bilateral innervation of the motor tracts. Extrapyramidal tracts. As I said, these are mostly involved in the basal ganglia. So when someone talks about extrapyramidal things, they're talking about basal ganglia. So as I said, these tracts are a little bit less well defined experimentally: vestibulospinal, reticulospinal, rubrispinal, tectospinal. There are some things to learn about what they do. I'm not going to spend a ton of detail about them, but it's worth knowing. They originate in the brainstem, but they do not pass through the pyramids. And they're really involved in unconscious reflexive or responsive movements, the control of balance, locomotion, posture, and tone. And just this diagram is a really nice one, and one that I would maybe draw out on your notebook or something, or do it on your own time. You have in the red, you have these descending motor pathways. So you have your pyramidal tracks. I know this looks like a pyramid. That's not the pyramids that we're actually talking about, but that's just helpful. So you have your lateral corticospinal tract, because that's on the lateral side, the far left side, okay? Sacral, lumbar, thoracic, and cervical. You have your anterior corticospinal tract. That's obviously the anterior part of the spinal cord, okay? You have your extrapyramidal tracts, which are kind of interspersed. There are some that are medial, there are some that are lateral, okay? And then in blue, you have your sensory, that's your ascending pathways. Okay, so obviously sensory information comes through the back of your neck. That's why your hair stand up at the back of your neck. So through that dorsal side, okay, and then goes up these blue ascending pathways. And the majority of your sensory information goes through your DCML pathway, your dorsal column medial lemniscus system. You have your gracial facialis and your cuneate facialis. Cuneate just means like wedge. This just looks like a wedge. Okay, so obviously a DCML pathway, most of that sensory information is going through literally the back of your spine, back of your neck. Okay, so that's how I remember it. And you also have these spinocerebellar tracts as well, which are involved in the cerebellum. So hopefully this diagram helps. And I think it's really important to get a good sense of the layout and the different roles of these different tracts. Even just at one part of the spinal cord, it changes throughout the spinal cord. But if you just get a good sense of being able to understand this diagram, I think that's really important for your revision and for your understanding. So as we talked about, there's lateral and medial ascending systems. I'm just going to leave this slide here. Some people find it easier to understand the differences between the tracts that are on the medial side, that is to say the middle of the spinal cord, versus the lateral side of the spinal cord, because there are some differences, but the rules don't always apply for each individual tract. But this is just a helpful slide if you want it. So I'm going to go just skip over for the sake of time, because it's quite a lot to get through on this presentation. So some information about the vestibulospinal, reticulospinal, rubrispinal, and tectospinal tracts. Those are all extrapyramidal tracts. You can learn about them in your own time, and I think you should for the sake of your exams. But like I said, the experimental evidence is a bit more unclear on what they do. And this is a bit more information about kind of how they are working with the motor neurons as well. So importantly, spasticity and rigidity, these are two terms that are used quite a lot in neurology and quite a lot in your questions. And it's really important to understand the difference because they kind of feel like they mean similar things, but they mean different things. So spasticity is velocity dependent increase in muscle tone due to the exaggeration of the stretch reflex. So that's to say, the more you're making that movement, you will get more and more spasticity. Okay, so why does this happen? So because a cortical lesion. So let's say someone's had a stroke in their motor cortex. Okay, and that will infect. So most of your cortical spinal tracts. I know I said they're involved with voluntary muscle movement. Okay, but a good chunk of them are actually inhibitory pathways. So they work by inhibition. They're stopping you from moving. Okay, and some will be involved with voluntary movement, but most of the time your body is telling your muscles not to move. Okay, or you can kind of think about it that way. And so your cortical lesions, your cortical spinal tracts are mostly inhibitory pathways. And without those inhibitors, a two-stage process occurs. So let's say someone gets a stroke. Initially, they just get complete weakness. Okay, so they get something called spinal shock. So you just see that they get complete weakness in their acute stroke. So maybe their arm goes and they're just acutely weak. Okay, so they're not spastic yet. But over time, hours to days to weeks, more permanent stage of hyperexcitement occurs. So the nerves, they all of a sudden have lost their inhibition from those cortical spinal tracts because they're not getting that information because there's been a stroke way up high in the brain. Okay. And they effectively get hyperexcitement of their own stretch reflexes. Okay. And they get some spindle activation and they start getting this really high tone. Okay. So they start kind of running their own show, and there's loads of synapses just going, okay, and you get a lot of spasticity. So someone with a stroke will start out really weak in the first days, and then eventually that arm will get much more spastic, okay. And you'll see this with people with cerebral palsy, okay. So they have ischemia, and very early on you might not see that they have spasticity, but then later on, when they're a 3 or 4 or 5 year old or a 10-year-old, you'll see that they very much have spasticity in their limbs or their arms, their legs. Rigidity is different. Okay, so this has it's increased resistant to ranges of movement. Okay, but it's not dependent on velocity. That's to say, if I move your arm loads up and down, up and down, up and down, rigidity is not going to change, whereas spasticity will increase the more I move your arm. Okay, you won't need much stretching or muscle reflexes or anything to notice rigidity. Okay. Okay. The stretch reflex is actually not involved at all. Okay. It occurs mostly in problems in the basal ganglia. Okay. So this is because people with problems in their basal ganglia are not going to have coordinated motor pathways, and it's generalized failure of those motor pathways, which leads to rigidity. Okay. So the problem is entirely in the brain. It has nothing to do with the stretch reflexes. And so a person may have both, may have spasticity and rigidity, but typically it'll be the Parkinson's patient has rigidity, the stroke patient has spasticity. So those are different things. And really important is something, as I talked about, the difference between upper and lower motor neurons is the Babinski sign. Okay, so this is effectively a stretch reflex. It's literally just testing the reflex of the lower motor neurons. Okay. So in a normal plantar response, you kind of scratch someone on the bottom of their foot, okay? And the Babinski sign is that the toe goes down towards flexion, okay? That's a normal Babinski, so that's a negative Babinski's reflex, okay? Let's say you scratch the bottom of their foot and their extensors go up, okay? That's a positive Babinski sign. That's very specific for an upper motor neuron lesion because, as I talked about, they've lost those inhibitory pathways that are going to get that flexion, okay? And instead they get this characteristic extension of the tones. Extensions of the tones. Okay. And really interestingly, young children, so infants before about 1 year of age, they don't have very developed corticospinal tracts because they haven't been moving very much. They haven't been developing those neuronal pathways. And so they will not have those inhibitory pathways that you need to inhibit that upwards Babinski reflex. Okay. So they haven't got this developed inhibition, and so they have upward going plantars. Okay. But that's completely normal. Eventually, children will then have down going plantars after about 1 year of age. So if you see a 3-year-old with upgoing plantars, that's pathological. If you see a 6-month-old with upgoing plantars, that's completely normal. Okay. And this is used quite a lot in evaluation of if people have strokes or not. So they'll come into A&E, you'll scratch the bottom of their foot. If they have upgoing plantars, there's some problem with the inhibition of their muscle stretch reflexes. Okay, there's some problem with those corticospinal tracts, right? And so we need to go looking for where that lesion is, probably somewhere in the brain. That's the Babinski's reflex. But there's loads of other different types of stretch reflexes that you can use, but Babinski's is really nice and easy and quite clear and quite specific. So a few important lesions to know about. So there's injuries to the pyramidal tract above the medulla. Those usually result in contralateral hemiparesis or hemiplegia. Hemiparesis, remember, is weakness of just one side of the body. Hemiplegia is complete paralysis of one side of the body. So paresis, weakness; plegia, paralysis. Paraplegia is complete paralysis below the waist, and quadriplegia is below the neck. So that's all four limbs, basically. And injury at the lower medulla, the spinal cord, and the peripheral nerves will have ipsilateral hemiparesis or hemiplegia. So it basically depends. If the lesion is above where the desiccation is, you'll have contralateral. If it's below, then you'll have the same side. That just kind of makes sense. Um, and they like to ask a lot in the questions, the MCQs, about the spinal cord syndromes. I'm not sure why, because they're very rare, but they are good at kind of evaluating if you understand that there's different locations within the spinal cord. Okay. So if you look on the diagram on the right, you have two sides of the spinal cord. You have the posterior side supplied by the posterior spinal artery, okay, and you have the anterior side supplied by the anterior spinal artery, okay, and you obviously have more central bits and more peripheral bits, okay. So there are anterior cord syndromes that result from, ischemia of the or hemorrhage of the anterior spinal artery. Those result in quadriparesis, paraparesis, okay, and the tracts that are involved are those that are supplied by the anterior spinal artery, which are your corticospinal, your spinothalamic. So you're not going to have good movement, and spinothalamic is really your pain sensation. So you're going to lose your pain sensation. Okay. There's also the dorsal column. So that's going to be entirely, like we talked about, that DCML system. So you're going to lose that proprioception, that sensation. Okay. There are complete cord syndromes where kind of everything goes. And then there are strange ones where, let's say, only lost those central tracts. Well, and it depends where the desiccation happens. You're going to have, some symptoms on one side, but different symptoms on another side because it's going to be above and below the decussation. You can go learn about Brown-Séquard and kind of try and figure it out. I always forget kind of the exact distinction, but it's something they like to ask about. It is absolutely frighteningly rare, and you will almost never see it. And there's other central cord symptoms as well. Brown-Séquard, sorry, is half. So like just the left side or just the right side, and then there's central cord symptoms as well. These are all really rare, but they're asked about on questions because they are good science showing of the anatomy. Another important clinical thing to know about is decerebrate and decorticate posturing. So easy way to remember: core, the arms go up to the core. So that's at the bottom there. That's decorticate. Decerebrate, the arms are extended. Okay. And decerebrate, the lesion is below the red nucleus. That's a little part of the brain, and it cuts off those corticospinal and rubrospinal descending fibers. In both of them, you're going to get lower limb extension. So as you see, this guy's got really extended lower limbs, but there's slight differences to how his arms are extended versus flexed. Okay, so one is decorticate, one is decerebrate. The important difference here is that decerebrate tends to be a bit worse because it means that the lesion is really deep in the brainstem as opposed to a bit higher up in the brainstem, which means you're kind of, the lower you go into the brainstem, the more you're kind of in deep shit in terms of how well the patient is. Okay, so this is just another diagram. So decorticate is above this red dot, decerebrate is below the red dot. In terms of Glasgow Coma Score, so this is how they often evaluate kind of how the level of consciousness of a patient. It's a quick scoring system. So GCS, because it will, the way it's scored, you'll get an M3 score. GCS, you'll get decerebrate, you get an M2 score. In reality, anyone who's decorticate or decerebrate is very close to impending death and probably going to herniate, because if there's a lesion to the brainstem, it probably means something's going really wrong with those tracts. And those are very important for kind of maintaining breathing and different functions of the brain. But it's just interesting to think about. And you will also see decorticate and decerebrate posturing in epilepsy, for instance, in people that are having seizures. But that doesn't necessarily mean they're about to die. But just something interesting to think about. Okay. Lower motor neuron disorders and lesions. So just important to think about. We talked a lot about kind of strokes and things. So what happens if you have problems with the lower motor neurons? Well, you'll have wasting. So you'll lose those lower motor neurons, which are directly innervating the muscle. And so you'll have loss of muscle bulk, because if you don't use it, you lose it, basically. And you also lose kind of trophic support. So in spinal muscular atrophy, there's a kind of a mutation of the SMN1 gene, which leads to dysfunctional SMN protein. And that protein is really important for kind of maintaining the health of the kind of the muscle and the nerves attached to the muscle. And so you kind of get this trophic problem as opposed to as well as a wasting problem. So it's not just that you're not using the muscle, it's that the muscle is actively being broken down because of the SMN protein problems. You get the kind of classic lower motor neuron distribution. So it will, follow the distribution of a particular nerve, whichever lower motor neuron you've chosen. You also get fasciculations. These are kind of wave-like mini tremors. There's really multifactorial reasons for why you get fasciculations in lower motor neuron problems. It's often because the kind of axons get a bit hyperexcitable through kind of ion channel dysfunction. You also, as you lose one pathway, the nerve will try and grow like a bit like a vine, like will try and like grow in different parts of the muscle. And then you get all these kind of alternate and faulty pathways that aren't fully developed. And that kind of leads to like pulsating, hyperexcitable, spontaneous discharge, which leads to this like weird fasciculation, like the muscles just kind of flexing a little bit in this really like wave-like fashion. You'll see this clinically. It's not really understood, I think, in detail why it works, but fasciculation is a classic sign of lower motor neuron problems, and particularly of things like ALS, which is actually both an upper and lower motor neuron problem. So motor neuron, as I said, ALS, classic disease of both upper and lower motor neuron signs. So you get a clinical vignette or some question and they say this person has, some upper sign, they have hyperreflexia, but they have fasciculations. Well, that's one upper motor neuron sign, one lower motor neuron sign. It basically has to be motor neuron disease. Okay. There's kind of tons of research into why this happens, a combination of genetic mutations, oxidative stress, mitochondrial dysfunction, protein aggregation. Really importantly, the sensory neurons are spared. So the way I remember that is people with motor neuron disease have this terrible disease, and it's terrible because they can feel everything about it. They like will feel everything. They won't necessarily be in pain, but they just, they won't lose any sensation. So really, really difficult disease and highly complex pathophysiology, which you're welcome to go and read about and research if you're interested. Okay, so cortical control of motor activity. So what actually happens in the brain? So there's how much time do we have? Okay, we're making progress, hopefully. The primary motor cortex, which is M1, that's in Brodmann area 4 of the precentral gyrus, so just anterior to the central sulcus. Remember, it means before, so just before the central sulcus. Wilder Penfield, I don't know why this is just something they often talk about. Wilder Penfield was this Canadian neurologist, neurosurgeon who basically figured out that if you kind of stimulate with electrical stimulation different parts of the cortex, you get different kind of twitches in different parts of the muscles. So he was the kind of first person to describe the homunculus of the motor cortex. Okay, the principal inputs, well, there's lots of inputs: supplementary motor area, kind of premotor somatosensory cortex, ventral anterior, ventral lateral thalamus. So all those integrating centers of the brain, because you have to like kind of plan that you're going to make a movement before you actually make the movement. So that's from the cerebellum and the basal ganglia. So a lot of the brain pathways are kind of quite complex circuits before the movement actually goes down the cortical spinal tracts. And then the output of the motor cortex will be that corticospinal tract, or the corticobulbar tract, as well as the striate and reticular formations, which are a bit less relevant. And basically the entire neocortex is involved in control of voluntary movement. So it's a big part of the brain in that M1. So here it's on the diagram. N1 stretches across basically the entire side of both sides of the brain at the cortex, so the very distal lateral parts of the cortex. And you also have, kind of other planning areas in the basal ganglia and the cerebellum. Okay. And, obviously if someone has problems to their prefrontal cortex, they're going to have personality changes or something, which may also affect their movement because they may decide to like do silly things. But so there's many different parts of the brain that are involved in movement. On the right side, this is kind of more of a coronal view. Uh, is this a coronal view? Yeah, I think so. So you have that central sulcus, and then you have those pyramidal tracts, as we talked about. That's your main corticospinal tracts. Okay, and you have different inputs from premotor pathways as well, and the corpus callosum. So you'll have inputs from the other side of the brain, and then there's also pathways coming from the thalamus and the cerebellum. Okay, and that's just the central sulcus there. There's the homunculus I talked about. So the way I remember it is it starts with the foot, and then you get hand in the middle, and then you get face at the bottom. So foot at the top, hand in the middle, face at the bottom, I think is a pretty easy way of figuring it out. And a lot of the time people will have like two or two of these three things going wrong, or you'll see just one thing going wrong. It's pretty rare actually for people to get like very, very specific cortical strokes that they just have like lost one toe, because typically people will have like ischemia to a broader area than that, or a lesion in a bigger area than that. Okay, so prefrontal cortex we talked about, posterior parietal cortex, the decisions, planning, spatial representation, all those kind of higher level thinking things, supplementary motor cortex, planning spontaneous bimanual movements. So there's a lot of kind of, in complex neuronal pathways that are happening before that kind of cortical spinal tract occurs, but in that motor cortex, which is an area four. Okay. And I think it's not so important to know so much about the various kind of circuits that occur before that actual corticospinal circuit, just because it's quite complicated and not entirely understood. But broadly speaking, you're going to have your high level strategy. So your planning, your motor cortex is going to be your planning, initiating, directing voluntary movements. You're going to have your basal ganglia, which is kind of coordinating a lot of these things. So that's your strategy. Your mid level, some people talk about, is your tactics. So that's really your cerebellum and your basal ganglia. Your cerebellum is very much involved in coordination. And then you have your brainstem centers, which are involved in kind of basic movements, postural control. This is like execution level. So, and then your local circuit neurons and your motor neurons, and then your finally your skeletal muscles. Okay. So it's good to just kind of separate these out in your mind. But it's quite complex. It's more complex than just this diagram for sure, in terms of how they're actually laid out in organization. Is just another diagram for your use. So kind of limbic reticular areas and sensory systems and your motivation. And then basal ganglia is really integrated in that planning phase, and then programming within the motor cortex and integration of different movements is really cerebellar. And then, you got your brainstem, spinal column, and finally your muscles. So I'm not going to go in detail, but there's kind of different inputs and outputs of the different areas of supplementary motor cortex, which are involved in planning in a more detailed way. So I'm going to skip these questions, but if you're on the record, you can pause the recording here and answer the questions for yourself. And I will wait 2 seconds, and then I'll reveal the answer. Okay, and those are the answers, so hopefully you got them right. All right, basal ganglia and what we're doing for time. Okay, hopefully getting through it. So basal ganglia is a very important part within the brain, which is involved really in the planning of motor movements. And many pathologies of movement that you'll see out in clinic or in hospital are people that have problems, not necessarily with their cortical spinal pathways or with their cortex, but really with their basal ganglia. So it's an extrapyramidal, as we talked about, that distinction, subcortical structure, which is deep in the telencephalon, and it has inputs from the cerebral cortex, especially the frontal, prefrontal, and parietal areas. Okay, so that it kind of outputs to the ventrolateral and ventral anterior thalamus. The thalamus, remember, is that kind of integrating center for a lot of what happens in the brain. So before, you get kind of input for the cortex, and then the basal ganglia will then send that information back to the thalamus, which sends it back to the cortex. Okay, so cortex, basal ganglia, thalamus, back to the cortex. And the function of the basal ganglia is quite complicated. It's really the selection initiation of voluntary movements. So it's kind of saying, okay, are we moving? Yes or no, and how? And it's really about goal-driven motor programs. And so people that have problems with the basal ganglia will either have real struggles with beginning movements or with stopping movements. Okay. It's not necessarily that they have problems with the movement itself. It's really like, can they start or can they stop? Okay. And there's different parts. So there's the caudate nucleus, the globus pallidus, the putamen, the subthalamic nucleus, which is just below the thalamus. And we'll talk a little bit more about these. Okay, so here are the components again. So this is again a coronal view. So if you split the brain kind of from front to back, and you have the caudate nucleus in the middle, you have the putamen on the outside, you have the globus pallidus, there's the external is on the outside, the internal segments on the inside, and then just below the thalamus, you have the subthalamic nuclei. So those are nuclear bundles below the thalamus, the subthalamic nuclei. And very often in diagrams and in circuits where these are drawn, it's worth just remembering what the abbreviations. So globus pallidus is GP, GPE is external, GPI is internal, subthalamic nucleus STN, and substantia nigra SN, and there's pars compacta and pars reticulata. Okay. And these are very much involved in Parkinson's, the substantia nigra. Okay, so direct and indirect pathways. So you might remember that there's parallel organization of functionally segregated circuits linking the basal ganglia cortex. That is to say, there's one pathway which is direct and one pathway which is indirect within the kind of circuits of the basal ganglia. The direct pathway is initiation of desired movement. So direct is like, okay, yes, let's go, let's start the movement. Okay, so it's cortical activation will excite the putamen neurons. Those will then inhibit the substantia nigra, the globus pallidus interneurons, and then you get kind of that goes back to the thalamus, okay, and you get that movement going. So yeah, move that leg, okay. So the thalamic activity will then boost your supplemental motor activity, okay, and that's positive feedback loop, and it gets that leg moving. The indirect pathway is really about antagonizing movement by thalamocortical relay, okay, so you'll get striatal output, which inhibits the globus pallidus externa, which reduces inhibition of the subthalamic nucleus. One thing that's really confusing about the basal ganglia is it's kind of like positive to negative to positive, so you have to remember that like it's like saying like, oh, yes, I'm not doing this, right? And so it gets confusing, but it's much more, I think a good way of learning it is to draw it out because it will make more sense when you kind of figure out that this is going positive, which is going to inhibition, which is going to positive. In general, direct pathways help select motor actions. Indirect pathways will suppress competing and inappropriate motor programs. Okay, so here is a very basic diagram. There's a million diagrams of the basal ganglia online. I encourage you to draw it out for yourself and make one for yourself that makes sense to you. Also, because on your exam, if you have an essay about the basal ganglia, you can just draw it, and then you don't have to, write long sentences and spend long time explaining that you understand how this works. You can just draw it, and then it's very easy to refer it in your essay that you're talking about the basal ganglia. Okay, so there's glutamate, there's GABA, which is inhibitory. Okay, so the direct pathway, cortex, striatum, with some dopamine input from the substantia nigra. Dopamine is extremely important to movement. Okay, and we'll talk about that a bit more. So dopamine is positive here on the direct pathway, goes to a negative inhibitory pathway on GABA to the globus pallidus interna, which goes to the thalamus. Inhibition leads to positive, which is again glutamate, which goes to the cortex. So that direct pathway ends in a positive output. Yeah, go move that leg. Whereas here, substantia nigra has a negative dopamine, so that dopamine is negative. You'll have acetylcholine, which leads to negative, which will lead to a positive glutamate on the globus pallidus interna, which then leads to an inhibitory, and then that will go back to the thalamus. Okay, you just need to draw this and understand it. I think it's complicated to explain it kind of on a call. I think it's best to just make it make sense for yourself. And this is another diagram, which is a bit more complicated. So on the left side, you have kind of the normal pathways. On the right side, you have Parkinsonism. So as you can see, some of the lines are a little bit thinner and some of the lines are much thicker. So that dopamine output, the globus pallidus externa in that indirect pathway is hyperactivated, okay? So what are the main basal ganglia pathologies? Well, you have Parkinson's disease, okay? So that's a disease of the subthalamic nucleus, okay? Which, as we talked about, is it's a disease of the substantia nigra. That gets confusing, okay? So you basically get problems of dopamine, right? Because the substantia nigra is very much involved with dopamine, which is involved with the motor pathways, okay? So in Parkinson's disease, you'll have basically overactivation of the indirect pathway and underactivation of the direct pathway, okay? And that results in obviously hyper-inhibited movement and the inability to move. So you'll have akinesia, bradykinesia, slowness of movement. Now, the kind of a different disease. And you also have drug-induced Parkinsonism, which is like you don't have Parkinson's disease, which is just like a kind of destruction of the substantia nigra through various processes. You have a drug which has caused the destruction as opposed to idiopathically. Huntington's disease is kind of the opposite. So you have a problem with the striatum itself, which is the central part of this pathway. And that actually leads to overactivation of the direct pathway as opposed to the indirect pathway. And so in Huntington's, you get too much movement. So it's like you can't stop. You can't put that stopping indirect pathway on, okay? So correspondingly in Huntington's, you get chorea, which is like dance-like movements, okay? You get involuntary, irregular, unpredictable movements that are very fidgety. So you see someone with Huntington's, it just looks like they they can't sit still. You may get dystonia, so they get involuntary muscle spasms, contractions, okay? It's just difficulty stopping movements, involuntary writhing movements, athetosis, okay? You might get bulismus, which is when you kind of get sudden hyper movement. So it's just like they stretch their arm out and then it comes back. You might get tics, which is sudden repetitive twitches, movements. You might get dyskinesias, which are involuntary movements of all kinds. So, a chorea is really a kind of dyskinesia, okay? These are all problems within the basal ganglia. They're problems with, can you start your movement successfully and can you stop it when you want to? Okay. And there's different parts of the basal ganglia. So you know Parkinson's disease and Huntington's disease are really your two best examples of basal ganglia pathologies, but many different drugs and diseases can affect the basal ganglia. That's the important thing to remember. So a bit more about Parkinson's that we talked about. So degeneration of the nigrostriatal neurons, which produce dopamine in the subthalamic nucleus, okay, which results in hypokinesia. It's basically a massive inhibition of that globus pallidus interna and the thalamus of those direct pathways. So you get the classic TRAPS syndrome. So tremor, which is a resting pill rolling tremor. So it'll be like, oh, I noticed dad was watching television and I noticed the hand that was holding the remote just kept rolling around. And that's the only thing that I noticed that was wrong with him. Okay. They'll get rigidity, they'll get akinesia, so they won't be able to move. Eventually, they'll get postural instability where it looks like their hips are shaking because they're just losing all their postural tone. Sorry, they're just losing the control of their posture. They'll get a shuffling gait because they find it really difficult to start that movement. So where they're kind of really trying to bring those steps forward and everything just gets reduced, the amplitude of their movements gets reduced because it's really difficult to get them started. There's also really important problems with sleep, cognition, and memory. And there's also problems with things like digestion and so on that can actually come before you get the movement symptoms. So the movement symptoms is actually like a later sign of Parkinson's. Okay, it's the second most common neurodegenerative disorder after Alzheimer's. There's lots of different causes: familial, genetic, sporadic, environmental causes. The pathology is complex, but it probably involves Lewy bodies containing alpha-synuclein aggregates that kind of build up and kind of screw up the subthalamic nucleus. Sorry, I keep making that mistake. The substantia nigra. I always get this confused. And then the key drug treatment, as we mentioned, well, what's the main thing that the substantia nigra is doing? It's producing dopamine. So how do you fix Parkinson's? Well, you give them dopamine because that's what they've lost. So typically you give them levodopa, which is a dopamine precursor, which they then will kind of turn into dopamine within their body. There's certain problems with dopamine, but it's the best drug and it's really the key drug for helping people with Parkinson's. There's other therapies. You can do things like deep brain stimulation. You can use other MAO or COMT inhibitors. You can do like stem cell transplantation. This is all like tertiary level kind of research level stuff. DBS is becoming more and more common, and that basically is just stimulating the brain to kind of get rid of some of that indirect pathway and kind of boost that direct pathway. That's what they do in DBS. Interestingly, there are some environmental causes of Parkinson's. So one is called MPTP. This is basically a toxin which is converted to MPP, a neurotoxin which binds dopamine transporters, and it induces programmed cell death in this substantia nigra. So you basically lose dopamine. And this is the reason that there were outbreaks of Parkinsonian symptoms in drug users, because they were basically had exogenous exposure to MPTP, which the body converted to MPP, which then destroyed their dopamine producing the substantia nigra. And then they all had Parkinson's, but it's because they were basically having exposure to these toxins. There's various other ones to think about, which you can talk about in your essays, which are all here and you can then Google on. But there's lots of environmental Parkinsonian syndromes, which are quite interesting and that show that you understand that it's basically a disease of dopamine. And Parkinsonism was also reported in various post-viral syndromes. So like viruses can shut down the substantia nigra and cause encephalitis lethargica. So this was, I don't know if you've seen the film with Robin Williams, where it's called Awakenings. But basically they all had a virus and then 20 years later, they all got Parkinson's, really bad Parkinson's. And then Robin Williams gives them dopamine and they all wake up and it's a magical movie. So just look into those things because they could be useful for your essays, but not key core information. Talked a bit about Huntington's, so degeneration of the striatopallidal neurons. So that's that GABA. So you lose that inhibitory GABA, leading to hyperkinesia. So it's very heavy input of direct pathway versus that indirect pathway, and you get decreased inhibition of the thalamus. This results in way too much movement. You can't stop your movement. You get this kind of dance-like movement, and the cause is kind of CAG, trinucleotide repeat expansion in the Huntington gene, which is in which causes the encoding of the Huntington protein, and there's then an accumulation of that protein which just disrupts the normal functioning of the neurons of the striatopallidyl neurons. And people, so in every generation will get an increasing trinucleotide repeat expansion. So if your mum got Huntington's at 45, you might get it at 35, and then your children get it at 25. That's the basic idea. But it's a terrible disease, and there's kind of more and more research into it, but it's pretty rare. You won't see it very often. And the treatment, as opposed to Parkinson's, which is dopamine, is obviously anti-dopaminergics because we're going to stop that movement. So tetrabenazine, neuroleptics, benzos, things like that. And okay, so I've just got a message that we're going to keep it. Try and keep it going. So we're almost done. We're just going to do cerebellum, and then I'll finish off. So here is again, for those in the recording, I'm just going to stop here. You can do those questions in your time, and then I'm going to count 5 seconds, and then I'll just reveal the answers. Okay, there's the answers. All right, let's just talk about cerebellum and then we'll finish off. So the cerebellum is inferior to the occipital and the temporal lobes. It's about 10% of brain volume, which is about half of all the neurons. It encompasses about half of all the neurons in your brain, which is pretty impressive. The function is really the coordination, calibration of movement. So people that have cerebellar issues will have difficulty kind of making their movements do what they want them to do, but they won't have problems with stopping or starting them. Their movements will be kind of crap. So it receives information, constant information about motor planning and intention and about motor performance. So it kind of integrates that proprioceptive information with that planning information, and it will modify ongoing movements to make sure that they're going in a direction. So a classic kind of cerebellar problem is someone is trying to like point their finger on press their nose and then point their finger and then touch your finger. Okay, and when they are stretching out to reach for your finger, they will shake and they'll go like they'll their movement will just be not coordinated, and they'll really struggle to make it go in a positive forward direction with any mapping, basically. It's kind of supervised learning. So it's like the cerebellum is really important for making sure that the movements are going as we want them to. And it's very important as well in balance. So integrates information between the sensory systems and the postural and motor responses to kind of maintain your balance so that you can just walk around and things like that. As we mentioned, it's extrapyramidal, so it's outside those corticospinal tracts. It projects via the thalamus to the motor cortex and then modulates brainstem motor areas. So it's quite a complex circuit. So there's different parts of the cerebellum. There's the cerebrocerebellum, which is involved in motor planning. The spinocerebellum really involves more in execution, and the vestibulocerebellum, which is more involved with balance and eye movements. Again, these are understood quite well, but not super well, and they're quite complex. But they have different nuclei, which I think is quite important to know. So on the cerebrocerebellum has the dentate nuclei, the spinocerebellum has the vestigial and interposed nuclei, the vestibulocerebellum has the vestibular nuclei. Okay. There's pretty complex pathways as to kind of how the different nuclei of the cerebellum are laid out, and I think maybe the best way to learn this is actually to just draw it out for yourself. But there's the dentate in the center there. The vestigial is kind of more the spinocerebellum. Vestibulocerebellum is really kind of at the back of the cerebellum. If you look at it this way, that's kind of someone's back of their head is facing you at the top left of this diagram. So motor planning is that dentate aspect. Okay. Here is a cerebellar pathway. You're welcome to kind of draw it out for yourself. I think it's probably, for sake of time, I won't go too much into the detail. But there's 3 types of interneurons that are basket cells, stellate cells, and Golgi cells. And I think more important to kind of really get set in your mind as to what cerebellar signs look like and what a patient will present with cerebellar signs, as well as the anatomy. Okay, so they'll have incoordination of their fine movement. Okay, so they'll have really bad handwriting, for example. They will have ataxia. So ataxia means that you think of a taxi, it goes a specific place. You ask the taxi man, take me to location A. Okay. Well, ataxia, they will not be able to take you to a specific, they won't be able to make their movement go to a specific direction. So you'll have staggering gait. It's like their legs will go kind of out of where normal gait should be. Okay. They'll have increasing difficulty of coordination of their balance. They will start to have tremor, so they'll have low frequency, high amplitude oscillations of their limbs. So that can also cause this kind of ataxia because they kind of have this tremor alongside their movement. Okay. And it worsens as it approaches the target. So it's an intention tremor, meaning it's worse when they're intending to make a movement. It doesn't just happen when their hand is sitting there when they're watching television. Okay. They'll have dysdiadokinesia, which means they have difficulty making rapid alternative movements. So let's say you ask them to clap their hands and then flip their hand over and then clap their hands again and then flip their hand over. Well, that's a rapid alternating movement, and they really have trouble with that. And they'll maybe clap twice, and then they kind of struggle with doing things in rapid alternative movements because those are different pathways, and coordinating that, it kind of takes more input. They'll have hypotonia. They'll have nystagmus, so that's involuntary rhythmic eye movements, which I'm sure will be reviewed by Laura in her cranial nerve lecture, but important to understand what nystagmus is. They'll also have dysarthria, so just as much as moving of their limbs and their legs will have problems, well, they'll have problems with moving their mouth and their tongue, which leads to slurred speech and difficulty speaking. Okay, so this is there's a classic mnemonic Danish pastry, which is like the 7 things that you will always see you might see in a person with cerebellar problems, and it's worth kind of remembering what are the few signs, okay? And there's different locations of the lesions. So obviously to the cerebrocerebellum, impairment of highly skilled sequences, spinocerebellum, shuffling gait, and vestibulocerebellum, they'll have postural ataxia, they'll have nystagmus. That's because of those different parts of the cerebellum, which you can review. So what are the key diseases of the cerebellum? There's spinocerebellar ataxia, which causes from CAG repeat expansion in ATXN. So it's a bit like Huntington's, but of the cerebellum. So they have ataxia, dysarthria, all those kind of classic signs. Friedreich ataxia is, again, a repeat expansion of the FXN gene. That's an inherited ataxia. There are a few inherited ataxias. All the ataxias are diseases of the cerebellum. Fragile X-associated ataxia, so that is X-linked dominant, so we'll kind of run through families through the mum. Multiple sclerosis, so MS is a disease of basically any upper part of the upper motor neuron system. You can get MS plaques that build up in the cerebellum that cause tremor and problems like that. You can get cerebellar cognitive affective syndrome, which causes very diffuse problems. So there's lots of different cerebellar pathologies. I think the important ones to think about are the different types of ataxias, and you can kind of go look those up in your own time. Another really important cause of cerebellar pathology is obviously alcohol. So you ever see a drunk person outside the pub? They have a kind of staggering gait. That's because the alcohol is literally toxic to their cerebellum, and so you kind of have, and it might be slurring of their speech. That's kind of all the signs of cerebellar pathology right there. Tumors can do it. You can get vascular strokes and trauma to the cerebellum. You can get tonsillar herniations. You can get paraneoplastic cerebellar syndromes. There's lots that can go wrong with the cerebellum. And here is some questions about the cerebellum, and I think we're done after that. A few minutes over time, but hopefully it's all right. So I'm just going to wait 5 seconds and you can pause, and then I'll reveal the answer. Okay, and that's the answers for these questions for those on the recording. Okay, I am not going to talk too much about eye movement and pupillary reflexes, but the slides are all here for you. I think Laura's going to cover it in a different lecture, but hopefully this lecture has been helpful to you. If you have any questions, feel free to email me. and there's some references and acknowledgements. And then importantly, if you could fill out the feedback form, that's the best way to get a copy of the lecture slides is through the feedback form. And then you can go through the slides, as much as you want on your own time. There's lots of information in the slides. I want to thank ZQ who made the slides and then I edited some of them. So she did a lot of the work. So thanks to ZQ who did the lecture last year. And then any general inquiries can go to the OSME preclinical email. You can also email me if you have any